Good morning, everyone. We're delighted to welcome everyone to another one of our quarterly visiting professors in colorectal surgery. We're particularly delighted to welcome David Bartlett from UPMC. Just a brief review of his career shows you just a long list of achievements and accomplishments from college and medical school in Texas to moving to the Northeast forevermore, actually, after that. I think Pennsylvania and fellowship in Memorial Sloan Kettering to developing and delivering an outstanding program of peritoneal malignancy and advanced abdominal malignancy in UPMC. Some 200 publications and many leadership positions and contributions to one of the most challenging surgical fields that we all encounter. So we're very interested in this topic, of course, in Orlando. It's something of a gap in Florida in general. We're looking forward to hearing what you have to say on treatment of metastatic GI cancer, and we welcome you here today.
Well, thank you. It's a pleasure to be here, and I really appreciate the invitation. And it's great to get to know AdventHealth a little bit. It's quite an impressive, complex, and program here. So what I thought I'd talk about a little bit is the surgical treatment of metastatic GI cancers, and I'll spend part of that with HIPEC, but I won't just talk about that, but just talk about the concepts a little bit overall. And this is something that I've been doing for quite a while. It's amazing how quick your career evolves. Or not evolves, but passes you by. So, I started doing this at the National Cancer Institute, where I went after fellowship. And at that time, I was really kind of trying to figure out. It was like an open field for us. I was recruited down there, and they said, do whatever you want, but 10% of the time you have to put in central lines. And I was like, okay. And then trying to think about, what the future of surgical oncology would be. We'd kind of done a pretty good job of saying we can take out more tissue in order to improve the outcomes. And then we got pretty good at saying, we can do it minimally invasively and take out less tissue and still have good outcomes. And that's really where surgical oncology was. And what I thought would be challenging for my career was to really say, how can we better manage metastatic cancers in surgical oncology? And along that lines, it made sense to say, how can surgeons deliver chemotherapy? So how can surgeons, by our surgical techniques and expertise, do better at delivering therapy to regionally confined metastatic cancers? Obviously, we can't do it throughout the whole body, but for regions that are involved with metastatic cancer, how can we better treat them? And so this is my computer. It should work. Interesting. It was just sleepy. Okay. As hopefully not all of you. I have no relevant disclosures. So a few case reports here. So this is a 45-year-old female with extremity melanoma. She was diagnosed, resected. You can see kind of where the primary was there, right above the knee, and then treated with multiple excisions, systemic chemotherapy, and she developed this massive, painful, weeping tumor that you can see. And the question is, can you take that out surgically? Well, you might be able to. You might be able to do an amputation that would address the disease. She had no systemic disease, but obviously suffering quite a bit from this. So this is a case where, what about delivering regional therapy to the leg? And this is a lady, 45-year-old female with abdominal distension, history of appendectomy 6 years ago with a mucocele. And then the CT scan 6 years later, she noticed the abdominal distension, and she has this massive amount of mucinous ascites. They tried to do a paracentesis, but they couldn't get the ascites out, and it's kind of a typical presentation that we see for low-grade mucinous tumors of the peritoneal cavity. So another disease that you could say, well, surgery, we can't excise all that, or it's not reasonable to excise all that, but can we do something for that patient? And this is another patient, 52-year-old female presenting with worsening constipation. Colonoscopy revealed a sigmoid colon cancer, and then a CT scan for staging revealed widespread hepatic metastases without other evidence of disease. So there are these patients out there, you've all seen them, that have fairly regionally confined advanced metastatic cancers, and what can we do as surgical oncologists to treat these? And these are the procedures that we not invented, but developed at the National Cancer Institute. Isolated hepatic perfusion, circulating chemotherapy through the liver, peritoneal perfusion, circulating chemotherapy through the peritoneal cavity, and limb perfusion. And just as an example of what can be accomplished, this patient received an isolated limb perfusion at the National Cancer Institute with a 60-minute exposure to melphalan. And that was it. That's all she ever got. I'm sorry, melphalan plus tumor necrosis factor, a biologic agent that we had available at the time. Those two drugs, 60-minute exposure, the tumor disappears and never recurs in the legs. She dies of lung metastases about 2 years after the perfusion. So really a nice result. Excuse me. And it's this result that kind of says, what can we do to make this happen in every patient that we treat? And this is this patient with this kind of massive mucinous ascites. We ended up reporting this case just because it was an interesting anecdote where this lady said, I've read about HIPEC, I know everything about HIPEC, and I don't want HIPEC. And she actually ran a website for patients with PMP. It's called PMP Pals. And she ran this website, and she helped people all over the world with this diagnosis. So she knew a lot. And she says, whatever you do, I don't want HIPEC. So I went to town, I debulked everything. She ended up in the hospital for a couple of weeks. I did not do HIPEC, but I got everything out. And a year later, this is her scan, it's all back. And so this time I said, okay, I'll do it again, but let me do the HIPEC. And so did it again, did the HIPEC, and here she is 4.5 years later without any evidence of disease. So it's an anecdote, but it kind of, again, an example of what can be accomplished with regional therapy, and why we want this to happen with every patient. It doesn't, but this is what we have to figure out, why it happened in her, and how can we make it happen in every patient. And finally, this patient with these widespread metastatic tumors to the liver, we performed an isolated liver perfusion with oxaliplatin plus 5-FU, followed that up with hepatic arterial infusion therapy with FUDR via pump, and 12 months later, all those tumors are just little calcified blobs, and she eventually recurred in the liver, but she lived about 4 years after the treatment. So all very exciting outcomes, and I think, as anecdotes, just what can be accomplished, but again, how can we do this every time? So just to go through a little bit of the options for unresectable hepatic metastases to start, because there are a lot, as you all know. Obviously, surgical resection, if it's resectable, is still the treatment of choice, and or radiofrequency ablation. But what happens when it's beyond that? When it's beyond that, we have these options. Hepatic arterial infusion therapy, which is the pump. I'll show a little bit about that. Isolated hepatic perfusion, which again is this very complex operation that we developed at the National Cancer Institute, but we still do perform today at UPMC. Transarterial chemoembolization, or TACE, and radioembolization, or yttrium. So these are kind of the options that I see for unresectable hepatic metastases. And just to talk about the hepatic pump, it's been around for a long time, since the 80s. And people were so excited in the 80s, this great technology. And you can deliver chemotherapy to the liver, it's implantable, doesn't have any side effects, and they started running trials at Memorial Sloan Kettering, and it was very successful. And then they started running randomized trials, and they were successful. And then there were arguments about whether those randomized trials had the appropriate control, so they ran more randomized trials, and those were successful. But every time a randomized trial would come out, in fact, we remember the big CALGB randomized trial with pump therapy that said pump is better than systemic. It was presented at ASCO, and the session after that presentation was a session on systemic FOLFOX for the first time. And FOLFOX compared to 5-FU-leucovorin, which was the standard systemic agents, FOLFOX had a better median survival than the pump. So it's every time you got a trial that showed the pump worked, you had a systemic therapy improvement that said, well, now we can use FOLFOX, we don't need to use the pump. And things like the pump are hard to use. And require surgery to implant the pump. And so a couple of things. One is that surgeons can manage the pump therapy better than the medical oncologist, because if we think that the pump works and we can help patients with it and we can use it as an adjuvant, then the easiest thing is for us to manage the pumps. And so we manage our own pumps, and you'll find that most centers that use hepatic arterial infusion pumps manage their own pumps as surgeons, because we're a little more comfortable with dealing with hepatic toxicities. And then I think the other advance is the robotic insertion of the pump. It used to be the patients came into the hospital, a big open incision, a week in the hospital to recover from the pump, complications, they have a bad wound infection. Now we put these in robotically. 48 hours later, we start their infusions, and they go home. 2 weeks later, they go back on systemic therapy, and we combine the systemic therapy and pump therapy. This is taking one of my fellows, in case you're wondering why it's so slow and deliberate. One of my fellows through a pump insertion here. But it's, of all the things that we do robotically, the pump insertion is the one that makes the most sense, because these patients with metastatic cancer, you don't want to hurt too badly with big open operations that might affect their ability to go on and get systemic therapy. And by doing it in a very simple way with minimal complications, it really changes things for us. So how well does it work? This is the latest results from Memorial, looking at a combination of hepatic arterial infusion therapy plus systemic chemotherapy for isolated hepatic metastases. And what you see here in this waterfall plot is that 70% of the patients have a greater than 50% reduction in their tumors. And even if they've had prior systemic chemotherapy and failed prior systemic chemotherapy, which is every bar there in the red, they still have a good response to hepatic arterial infusion therapy when combined with systemic chemotherapy. So it's not a single just infusion therapy, but it works very, very well. And if you look at the survival in their series, it's really quite remarkable. If you look at chemo-naive patients, they have a 60 to 70% 5-year survival with unresectable hepatic metastases, which really is about what we used to see with resectable hepatic metastases. And if you look at overall, it's about a 50% 5-year survival using hepatic arterial infusion therapy. So this is a good treatment. It does work. We still use it. The only issue is it's complicated, and you have to be comfortable with it, and you have to be comfortable managing patients with it. We train our fellows to be comfortable with it, so they go out and they start programs at their institution. So slowly we're seeing more and more institutions develop hepatic arterial infusion therapy, even though it's been around for 40 years now. And we did a case control study in Pittsburgh, matching patients that did not get referred to us for hepatic arterial infusion therapy or did get referred to us for hepatic arterial infusion therapy. We matched the cohorts as well as we could, and then looked at the difference in survival. Those that got the hepatic arterial infusion therapy plus chemo, 33 months versus 15 months chemotherapy alone, which is kind of what you would expect for this population treated with systemic therapy. So not a randomized trial, but at least some evidence that this is effective. And we also did a case control study of hepatic arterial infusion versus Y90, and we also saw a 31-month median survival for hepatic arterial infusion versus 16 months for Y90, again, suggesting that we can do much better with hepatic arterial infusion. And we've gone through all of these. We've treated patients with TACE for a long time. We've treated patients with Y90, and really, in our experience, the hepatic arterial infusion therapy is still the most effective when combined with systemic therapy. So this is just another example of HAI therapy. What we did in this study is looked at cholangiocarcinoma confined to the liver. And we compared surgical resection. So if they were anything above a stage 1, surgical resection versus hepatic arterial infusion therapy for unresectables versus TACE for unresectables, and compared these three groups. And basically they were, for the most part, comparable, except, as you might imagine, the ones that were unresectable had kind of worse disease overall, bilobar disease, larger tumors, higher incidence of nodal metastases. So you really had a much worse group getting hepatic arterial infusion therapy. But if you look at the 90-day morbidity, less with the hepatic arterial infusion than surgery. Progression-free survival was better with hepatic arterial infusion therapy than TACE. And the overall survival, if you look at the overall median survival, for hepatic arterial infusion therapy, it's 42 months versus 20 months for surgery and 15 months for TACE. And that's shown in this group. So you take a worse group with more advanced tumors and you treat them just with infusion therapy and systemic, they do better than patients that underwent resection. And this is overall survival. So those patients that underwent resection recurred, they got salvage therapy, and they died before those patients that were just treated with hepatic arterial infusion therapy and systemic therapy combined. So, you know, it just shows you surgery is not always the answer. And it's always a frustrating thing when you talk about surgery for metastatic cancer. You take the tumor out, all the tumor that you can see, and they have a worse survival. And there's a lot of mechanisms for that. The patients will tell you the air got to it and made the cancer grow twice as fast. But those of us that deal with metastatic cancer know that surgery and the stress of surgery, and especially if you have a complication from surgery, it accelerates the growth of the tumor. And so in some ways, you can do better not operating and allow the tumor to kind of continue along its way than operating, that then accelerates the growth and allows for a very rapid recurrence and death of the patient, especially if you have infectious complications. And we now know that that's probably related to the immune system, but the innate immune system and what we call NETs, neutrophil extracellular traps, that in the setting of stress and infection get showered on these tumor cells and protects them and helps them spread and helps them grow. So there's a lot of things that people have explored, but we're getting down to true mechanisms as to why that happens. But it's something that you always have to think of in the back of your mind when you're talking about surgery for cancer, that sometimes you can do worse than if you just left the patient alone. So now just to switch gears into isolated hepatic perfusion. So it was our thought, you know, if we can just infuse the liver with chemo, what if we perfused the liver? You know, took the liver out, hooked it up to its own heart-lung machine, and circulated chemotherapy through the liver. And that's, in effect, what we did. We completely isolated the liver. We hooked it up to a heart-lung machine with an oxygenator, circulated, and we can control that environment completely. We drop the pH down, we increase the temperature, we start adding chemotherapy agents, and come up with kind of the best environment that allows the tumor to die and the liver to live. And we circulate chemotherapy through the liver for an hour. And we've done this for a long time. Did it at the National Cancer Institute and then brought it to Pittsburgh. We've done it there. We've run probably about 6 clinical trials, and then started doing it off clinical trial just as what we call innovative therapy for patients without other options. This was a trial looking at 5-FU and oxaliplatin combined in the perfusate, and we saw an 83% radiographic response rate in a phase 1 study, which is pretty remarkable. And this is an example of a patient that was cured with widespread metastatic disease. You can see pretreatment on the left. 6 weeks later, things start to shrink, and then 6 months later, they're all gone. The patient had an isolated recurrence in a lymph node that we took out about 2 years later and then never recurred. And she's so anyway, an example of somebody that did well with that approach. And we looked at all of our overall survival in patients undergoing isolated hepatic metastases for liver metastases from colorectal cancer at UPMC. And you can see here our median survival is 36 months overall, and our 5-year survival was about 20%. The problem with this, from my perspective, is that we see just as good results with hepatic arterial infusion therapy combined with systemic. And the isolated hepatic perfusion has an 8% mortality rate. And it has an 8% mortality in our hands, has an 8% mortality in everybody that's tried this technique. And the problem is we can't trust the liver, and the whole process, it's like doing a trisectionectomy in a liver. You're going to have a defined mortality rate because you can't predict whether the liver is going to recover or not completely. You try, but you can't. And so to have 8% mortality and to have a response rate and an overall survival that's similar to hepatic arterial infusion therapy, which has literally no complications associated with it, or minimal, we decided to abandon this for colorectal metastases. But for ocular melanoma, it's a weird tumor that just metastasizes to the liver and usually looks like this when you actually look at the liver. Pigmented lesions throughout. It doesn't just come in one spot that you can resect. It doesn't respond to FUDR, which is what we can use in the pump. We can do isolated hepatic perfusion in these patients and still have a reasonable outcome. Our median survival is about a year. And interestingly, these patients don't have an 8% mortality. The reason, I think, is that the livers are healthy. Colorectal livers are not healthy, and it may have something to do with the diet that got them to the cancer in the first place, or it may have something to do with the chemotherapy that many of them have received prior to coming to us. But the ocular melanoma livers are healthy, they tolerate the perfusion, and we don't see the mortality rate associated that we see with the colorectal cancer. So we continue to do it for ocular melanoma. We have 12-month median survival. Right now we have tumor-infiltrating lymphocyte therapy trial for these patients as well, and we're seeing some good long-term effects with that. So ultimately, I don't think this is going to be a long-term strategy for these patients because we're not curing them and we're putting them through a big operation. But for right now, it's a reasonable option. And if you break it out by LDH, those with a low LDH seem to do very well. So low-volume disease basically does very well. And there's just an example of an MRI with just widespread metastases you can see that all disappear with isolated hepatic perfusion. So I'll move on now to peritoneal metastases. And, that I had a case when I was an intern where a young guy who was in his mid-20s, he comes in with what we thought was appendicitis. At the time, We didn't stick a camera in. We made an incision. And we looked inside, and he had just small little spots of peritoneal metastases, and biopsied one of those. And it was metastatic adenocarcinoma coming from his appendix. We closed him up, and we we talked to his family. We said he's got metastatic, appendix cancer. There's nothing we can do. And we didn't have hospice at the time, but we basically just watched him die in the hospital. We just said, this is too much, nothing that can be done, peritoneal-based disease. And, unfortunately, as you might imagine, a 25-year-old with peritoneal-based disease takes a long time to die. And so he did not get IV fluids, and I had to round on him every morning. It was a very dramatic thing for me. So the point is that we can do a lot better with peritoneal metastases now than what we did then, but it does kind of inspire you to how can you better manage these patients. The other thing is that these patients really have a horrible symptoms and a horrible way to die. To me, it's worse than any other cancer. I'm sure somebody could argue with that, but I think dying of progressive peritoneal metastases is the worst way to suffer and die from cancer. You've all had a bad belly pain. You've all had food poisoning at some point. You know what it's like to feel sick. Well, imagine feeling sick every day, and some of these patients for years for these slower growing tumors. So a bad natural history, and one that if we can solve the problem in the peritoneal cavity, even if they die of lung mets, we've saved them a lot of suffering and prolonged their survival. And it's a lot of different etiologies that cause peritoneal metastases, and kind of levels of aggressiveness. You have these low-grade mucinous tumors, pseudomyxomas, some of these more benign mesotheliomas, and then very aggressive gastric, pancreatic, small bowel. And you kind of have to think about the aggressive nature of the tumors in terms of how best to manage them, and keep that in mind. In just a few slides, this is a low-grade papillary mesothelioma, which is extraordinarily extensive, as you can see. But at the end of a long day, you can get every single one of these nodules out. And you can imagine it's morbid, it's going to hurt the patient, but you remove all this disease, you treat the peritoneal cavity, and they have a very, very good outcome with these papillary mesotheliomas. And just to point out that all peritoneal disease isn't the same, you have the kind of colorectal metastases here. You have this kind of infiltrating mucinous high-grade signet ring cell carcinoma here. You have this is kind of a low-grade serous ovarian cancer, and you have low-grade mucinous neoplasm of the appendix here. So obviously all peritoneal disease isn't the same, and these are all much different than the mesothelioma, which I showed. And the low-grade mucinous tumors of the appendix aren't all the same either. They start in the appendix, they rupture, and then they contaminate the peritoneal cavity, but you have a wide range from true benign neoplasms to these highly aggressive malignant signet ring cell or poorly differentiated goblet cell cancers. And even in the low-grade tumors, they're not all the same. Some get scarred in like this, where you can see it just pushes the bowel, causes bowel obstruction. You've got a lot of septations. These are just hard as a rock, scarred tumors. And then you have this, which is just soft mucinous ascites that you can scoop out with your hand. And so even if you talk about the low-grade mucinous tumors, they're not all the same. And so you kind of have to be comfortable with all of these things. And what we started working on in the early 90s was this combination of peritoneal surgery and heated intraperitoneal chemotherapy. At the time, it had just been shown in Japan that a randomized trial of HIPEC, oh, this is going to be really painful. Oh, that's going to be so painful. It's just not even supposed to happen. All right, so we're going to just talk a little bit here. How's that? So, uh, unbelievable. So anyway, so this combination of heated intraperitoneal chemotherapy and surgery was shown in Japan to improve survival in gastric cancer patients with peritoneal carcinomatosis. And so we started to say, because at the National Cancer Institute, we had this program, we're thinking about how do we treat metastatic cancers. It's like, let's see what we can do with peritoneal metastases. And so we brought that to the U.S. and started developing these techniques and running clinical trials for HIPEC in GI cancers in general. And we had trials in pancreas cancer, we had trials in gastric cancer, and then appendiceal and colon cancers. And looked at different drugs, different ways to deliver it, combining the HIPEC with intraperitoneal therapies, and a lot of different approaches. And never really got to the point of randomizing patients on these trials. It was always phase 1, phase 2 trials. And so, this is kind of my regret, I think, overall, is that, when you have an idea and and you want to move forward, get to a phase 3 trial as soon as possible so you can really start to answer questions. Because so HIPEC has been around since the 80s. And what's happened in the United States and internationally really is it's slowly grown since then. And now there are programs all over the world, all over the country, using HIPEC for peritoneal metastases, but we don't have enough data to say this is how it should be done. It's not mentioned in NCCN guidelines. There's not strict algorithms of how we should be doing this, and there's not enough data to fall back on. And that's because we just don't have enough randomized trials using this technique, and that's because we're surgeons, and surgeons get busy doing other things and don't sit down and run randomized trials. And there's a lot of reasons why it's challenging to run randomized trials for surgical procedures. So you can't see it, but it says this will take a while, just in case. It's working on updates. Okay, so what happened? So we became interested, ran these kind of phase 1, phase 2 trials. I then moved to Pittsburgh. And in Pittsburgh, I said, listen, we got to start these programs in Pittsburgh. So we started the isolated liver perfusion. We started the HIPEC program. We started our isolated limb perfusion program. We started offering these to patients. And in a blink of an eye, 10 years goes by. We've treated 2,000 patients now with HIPEC. We've written at least 50 papers on HIPEC, but we still don't really know enough about who we should be doing it for and what makes sense. So let's talk about colorectal cancer. So colorectal cancer with peritoneal metastases, in about 2001, a randomized trial from the Netherlands showed that there was an improvement in median survival in patients that received surgical cytoreduction and HIPEC with mitomycin C. It's a 90-minute treatment. The control arm received 5-FU systemically, and some of them palliative surgery, but nobody tried to remove all their tumors. So it was a completely clean randomized trial of 80-some patients. The results were that the median survival in the patients that got surgical cytoreduction and HIPEC was 22 months, and the median survival in the patients that just got systemic 5-FU was 10 months. So it was a positive trial, pretty significant, but not huge numbers. And if you think about it, that randomization was for nothing versus everything. In other words, no surgery versus complete cytoreduction and intraperitoneal chemotherapy or HIPEC. But nevertheless, that trial gave the justification of what a lot of us were doing anyway, which is trying to treat patients with HIPEC with colorectal mets. So we all kept doing it. In France, they said, um, we can do it better with oxaliplatin instead of mitomycin C. And the surgeon in France that started it in France said, I cannot, and this is literally why he did this, he said, I cannot stand in the operating room for 90 minutes while a patient's getting chemotherapy. I can do it for 30 minutes, but I can't do it for 90 minutes. And so he said, I'm going to do 30 minutes of oxaliplatin, and we're not going to overheat it, but we're going to heat it to about 40 degrees centigrade. Isn't enough to kill cancer, but maybe it helps the chemotherapy work a little better. Maybe it helps the chemotherapy penetrate a little better. So we're going to do 40 degrees centigrade of oxaliplatin as our therapy. And so they did it, and they did it well. And they wrote it up, and they got everybody else in Europe to do it. They had a lot of cooperative groups together that treated patients with this 30 minutes of oxaliplatin, and they began to write papers, and they wrote a lot of papers. And their results were way better than our results. And they had a median survival of 36 months. In fact, one study where they did a nice case control of patients that received it versus not, they had a median survival of 48 months, I think, in their arm that got the HIPEC, this 30-minute oxaliplatin HIPEC, versus like 18 months in the patients that didn't. So suddenly we have this thing, HIPEC with oxaliplatin works very well. And a lot of people switched. People in Canada switched to oxaliplatin. Like I said, all over Europe, everybody started using oxali. We were a little stubborn in the United States. We kept using mitomycin C. Oxali isn't one of those drugs that you would expect to work as a single agent. So we used a different drug. So then the French did the right thing, which is we're going to run a randomized trial and prove how well this works. And so they spent 6 years running a randomized trial, 2 years in follow-up, and then published the results this year of their randomized trial. And the randomized trial showed absolutely no benefit to HIPEC whatsoever. But they did show a 42-month median survival in both arms. So even if and the difference is, compared to the study from the Netherlands, is that they included cytoreduction. They didn't randomize the patients until after the cytoreduction. So you went in, took all the tumor out, then flipped a coin. You either got HIPEC or you got closed. And so there wasn't a difference, but those patients that were getting cytoreduction and HIPEC had a median survival of 42 months. So, what do we do with that information? Do we say HIPEC doesn't work? Do we say HIPEC may still work with mitomycin C, but it doesn't work with oxaliplatin? Or do we conclude that cytoreductive surgery should be done in everybody with metastatic colorectal cancer? And that's where the field is right now, is trying to decide how to interpret this data, how to move forward, and what do we do with HIPEC overall. I think the general consensus is that their 30 minutes of oxaliplatin is nothing like 120 or 90 minutes of mitomycin C. And so the conclusion can't be that mitomycin C doesn't work. It just has to be that the oxaliplatin doesn't work. And I have to say, just about overnight, nobody does oxaliplatin perfusions anymore. So it's gone away. Even in France, no longer doing it. They have switched to mitomycin C. So they kind of also said, we don't want to give up on HIPEC. There's a lot of people that have built their careers around this. They don't want to give up on it, but we're going to switch to mitomycin C because clearly oxaliplatin doesn't work. And I think that's kind of where we stand right now, is that mitomycin C may work. But what it means is we got to do the same trial with mitomycin C, because we think mitomycin C works, but we haven't randomized it in the way that they did with cytoreduction alone versus cytoreduction plus HIPEC. And so that's kind of where the field stands. They also ran in France a randomized trial of adjuvant HIPEC in patients that were high risk for peritoneal metastases. And so they took those patients with ovarian mets, a single peritoneal met, or T4 tumors, colon tumors, and they randomized them to a second look at 12 months after the surgery and a HIPEC at that point. And those patients also had the exact same survival whether they got HIPEC or not. So again, HIPEC was not helping, but it was this 30 minutes of mitomycin C that they were using, and not the 30 minutes of oxaliplatin and not the mitomycin C. So so that's where we stand. We did just kind of go through a consensus conference in the United States to say what should we be doing with these patients, and have decided that we should move forward with a clinical trial of mitomycin C, and we're working through one of the cooperative groups to get that started. And we still do offer the HIPEC with mitomycin C for patients with colorectal cancer. But in the back of my mind, I say to patients, we think now that the cytoreductive surgery makes sense, good systemic chemotherapy makes sense, and we think the HIPEC may help a little. But it's not about the HIPEC. It's really about trying to clear all the gross disease in the abdominal cavity. Now, for other histologies in the abdominal cavity, we have different results. There was just a nice randomized trial from the Netherlands looking at cisplatin HIPEC for ovarian cancer. They took these kind of aggressive, high-grade serous carcinomas of the ovary, and they treated them with systemic chemotherapy first. They took them to the operating room, did a complete cytoreduction, and then randomized, flipped the coin on the table to either receiving HIPEC or nothing, and then going back to systemic chemotherapy afterwards. And in that study, it was published in the New England Journal of Medicine last year, there was a statistically significant improvement in survival in those patients who received the HIPEC versus those that didn't. So now we've kind of opened this door. There's another randomized trial from Greece in patients as salvage therapy for high-grade serous ovarian cancer. Once they've had their debulking, they've had their chemotherapy, and then they this will take a while. Thanks for the update. They've had their chemotherapy. Then they fail in the abdominal cavity, take those patients back, do that same randomization. Those patients also do better. So now we have this kind of interest in HIPEC for ovarian cancer that I think is real, and we have some reasonable data associated with that. Mesothelioma, we talked about a little bit. It is, for mesothelioma, it can be like magic in my mind. We have these patients with massive ascites, kind of bulky disease like what you saw in that film. We cytoreduce them, treat them with cisplatin perfusion, and they never recur, some of them. And they don't get any other therapy for these low-grade mesotheliomas. And so, clearly we are changing the natural history for those patients, and we do have an impact on those patients. So there are still, I think, things to explore in the HIPEC world beyond colorectal cancer, and still a question in colorectal cancer is kind of how much impact we're having. But I think it all comes down to the problem that we talked about in having good randomized trials that can really tell us what the benefit is and how much benefit it is. And that's where we stand right now. My kind of long-term take on it is that peritoneal surgery is a specialty in surgical oncology that is here to stay. And it is kind of a unique interest, a unique talent, expertise that can be developed and trained for. There are enough of these patients out there that need surgery, just like liver surgery and surgical resection is a specialty. So should peritoneal surgery be a specialty. So I think peritoneal surgery is here to stay. What I don't think is HIPEC is here to stay. I think we can do better than HIPEC in the long run for these patients. We just have to be innovative, and continue to explore better opportunities. Because even in the best of studies that we have, we're only moving the bar a little bit with what we're doing, and we need to do better. And so I think peritoneal surgery is here to stay, but HIPEC, we need to do better. Right now, that's the best we have, but we need to explore. And that's what I've been doing in the laboratory, is looking at what other agents can we deliver into the peritoneal cavity that will do better than HIPEC. And in the medical oncology world, things have evolved from standard chemotherapy to targeted chemotherapy, targeted agents, to immune therapies. And in the surgical world, we're still giving mitomycin C, which went out of favor in the 1950s. So we have not evolved as the drugs and the treatments have evolved. And so, my goal in the laboratory is to say we got to move forward, and what other agents can we use. And so I've been interested in immunotherapy into the abdominal cavity. And so what we do is we have animal models of tumors that we've taken from the patients, kind of xenogenetic models, and we have murine syngeneic models of peritoneal metastases. And we look at regional delivery of immune therapy into the abdominal cavity. And it would be great if we could get from 84% to 100%, so I could show you some of this. And I'm sorry, we could have just loaded on something different by now. I didn't know it was going to take this long. What I've developed is oncolytic viruses. So I take a vaccinia virus and a very aggressive strain of vaccinia virus. It's I liken it to smallpox because it is the most aggressive strain of vaccinia virus, and pox viruses in general are incredibly aggressive. And smallpox could take over an entire human body in about 5 days. So it would go from a tiny little inoculum to taking over the whole body and killing the patient in about 5 days. So we take a very aggressive pox virus, and then we developed some mutations that allowed it to be completely selective for tumor and not replicate in normal tissues anymore. And then we took that virus and tried it in different clinical trials, local injections, and different things. And I've been basically working on this for 20 years. But what we found is that by delivering it into the peritoneal cavity, we can get a very nice distribution of the virus. We can infect all the cells in the peritoneal cavity. It will divide into cancer cells, and we can express immune transgenes from the virus that then create an immune response. And we can take a tumor in mice that has no baseline immunogenicity, so it won't respond to checkpoint inhibitors, it won't respond to other immune therapy, and then we can inject this virus with the cytokine, and then it transforms that tumor into a very immunogenic tumor, then kind of come in with a checkpoint inhibitor and cure these mice with kind of advanced peritoneal metastases. So we cured mice with peritoneal metastases. And now we have made one of these viruses in clinical grade, and we've sent to the FDA a trial of delivering that into the peritoneal cavity for patients with advanced peritoneal metastases. And so to me, the future is let's look at novel agents. Let's keep up with the agents that are being used in medical oncology, and keep up and try these novel agents to try to manage peritoneal metastases. Again, the problem is just working through these trials and making sure that we continue to explore these things. If this happens to open up in the next 2 minutes, I'll show you a couple slides, but otherwise I'm happy to answer questions at this point. Thank you.
Thank you very much, David. Nobody should have to suffer that during any talk. So where do you stand? Give us, as you say, there aren't classic algorithms for it because these patients are all individually challenging. But in essence, what is your sense of algorithm for patients now with peritoneal disease from colorectal cancer?
So a couple of things. If you find peritoneal carcinomatosis when you're exploring to take out a colon cancer, what do you do, right? So do you just stop at that point? Get the patient. So I guess what I would say is here's what we do. If you are exploring a patient with colon cancer and they have peritoneal metastases, we would say stop. Don't take out that colon cancer, assuming it's asymptomatic. And get that patient onto systemic therapy. They would go on the 3 months of systemic therapy. We would kind of see how they respond. If it looks like they're having good response, then we would go in, take out the primary, take out the peritoneal metastases, and do the HIPEC at that point with mitomycin C. The other option is if you go in, the patient has peritoneal metastases and they have a symptomatic primary, and you're going to take out that colon cancer, what should you do with the peritoneal metastases? In my mind, based on the French data, you should take out all the peritoneal metastases. Now, we use a PCI score to kind of measure the peritoneal volume of metastases, and if you're going to do a cytoreduction, it should definitely be less than 20, that PCI score. So that means kind of moderate volume at most. If it's high volume, you're not going to help them. Just stop. Do what you have to do to salvage the peritoneal or the symptoms and stop. So anyway, so that's kind of how we would manage it.
And then you will go on that first look up to additional organ resections, or will you stop shy of multivisceral resection?
We will proceed with multivisceral resections, but I think it's what you're comfortable with and what you think the patient can handle and is ready for, and how much discussion have you had with the patient, all those things. But yeah, I would do it all at the same time.
Now, about two other quick questions. One quicker question is the Bartlett trial, blew everything out of the water in terms of oxaliplatin. Do you think there's any justification in the thought that it was the 30 versus the 190 minutes rather than the oxaliplatin versus the mitomycin? In other words, should the trial actually been repeated with 90 minutes? Because it's, I've watched chemosensitivity over 30 years, and we continue to use an agent that doesn't work in colon cancer. At least oxaliplatin works in colon cancer. Is there some reason to think it's just the way it's being used?
It's possible. And hyperthermia, every study that's ever looked at hyperthermia in vitro, including our own, requires 2 hours at 42 degrees centigrade to have any cytotoxic effect. In fact, if you look at cell growth in a dish at 40 degrees centigrade for a half an hour, you've actually accelerated the growth of the tumor. So I have the argument that they're not, having the same cytotoxic effect from the hyperthermia. But also, you could argue that the oxaliplatin needs a longer exposure. What they've done, and oxaliplatin can work as a single agent in vitro, but it doesn't work well. And it's never worked in vivo as a single agent. It's always had to be combined with 5-FU. So what they've done, and in that trial I didn't mention it, but they give intravenous 5-FU at the same time that they're doing the HIPEC, with the thought that maybe but they have no clue as to whether that intravenous is really getting into the peritoneal cavity, into those cells. So you could also argue that they should have delivered 5-FU with oxali into the peritoneal cavity.
Questions?
If I remember right, the more or less lung cancer data showed that after completion of liver, and when the percent, about 40% different. Is that your experience there?
Yes, same experience. And that's in their data. They compared kind of their, um, actually, we compared our, it's on one of those slides. We compared our resection rate in that case control study. And I think it was 20 to 30% in our HI group versus like 5 to 10% in the systemic group. So it was better. Yeah, and they're a little bit challenging operations, but definitely can operate in those folks.
Is there any benefit to going back and repeating your debulking?
Yes, I think it's unrealistic if you think about it especially for some of these more bulky disease patients, for a single exposure to an agent. We show some examples, but in general, therapy needs to be repeated. So, I ran a trial at the NCI where I did just that. I said, every other month, we're going to take you back and we're going to do the peritoneal wash, which, because I was young and naive, I thought I could get away with that. And what happens is patients won't come back.
Yeah.
It's too big a surgery. So you don't really have that option, I think, of repeating it. So what we do is wait until they recur. But when they recur, or you see that CEA level start, you try to jump on them as quickly as possible. And I do think it's more in the kind of low-grade tumors than the high-grade tumors, but we do get to that stage where you start out with a lot of disease, you debulk, they recur in a year, but they have less disease, you go back, you debulk, they recur in 2 years, and they have even less disease, and we eventually get them to a point where they live a long time. So we do have kind of examples of those patients. So that's more how we manage it. Wait, follow closely. When they recur, try to jump on it early. And we've done up to 8 perfusions in a patient who's over about. It happens, but it's more, I think, patient specific. Some patients just scar like crazy and you can't get back in there. And in some patients, you can do 8 times and still get back in there. So no question it gets a little rougher each time. The other thing is that the patients suffer a little more each time. I'm amazed, I just did a guy who was about 4 years out from the first debulking, and I thought, this was easier than the first one, and he was young, and he would tolerate it just fine, and it just knocked him down, and he never recovered. So these are tough operations and tough on patients to repeat, for sure.
Do you know Martin Goodman in Tufts?
Yes, he trained with us. He was my first fellow, actually. He was my first fellow.
Oh, really? Okay, wonderful guy. But he would do these cases there, and they would come back with abscesses and fistulas and all kinds of complications. I said, well, don't treat them like the usual patients. You just got to wait them out, got to grade them, and so on. And it was amazing that we had patients fortitude to do that.
Yeah, it is true that you can't jump back in on those patients because it'll be a cement abdomen. You'll create more problems than you had. And yeah, we're very conservative about those kind of things. And I think the worst scenario is when they go to an outside hospital, they get taken to an emergency room, they get taken to an operation, and then you have a hard time getting them through.
One last question on the topic of hepatic perfusion. How often do you actually get hepatic failure?
So that's what I was saying. 8% of the time, hepatic failure, death in our colorectal population. And I looked at that number in a trial from the Netherlands, in a trial from Sweden, and a trial from Italy. And we all had the same numbers. And it's been abandoned internationally except for ocular melanoma. So they've come to the same conclusions we have independently, that for that disease, they do okay. And
this is the hyperthermia.
The peritoneal, the liver perfusion.
No, liver perfusion.
But your hepatic artery perfusion
still using it
Yeah.
for colorectal.
Yeah, yeah.
Yes, the isolated perfusion for octo.
Yeah.
I remember even as a resident, in early year, Matt coming through a lot of this, there was a big push to do it. You did a number of them, and then it just seemed to drop off. But it still seems to be done in isolated locations.
It dropped off, and then what you're seeing now is it's coming back. It's remarkable, but yes. And again, a little embarrassing that we haven't evolved from 1980 in terms of the drug, the way it's delivered. But now it's the combination of the infusion plus systemic, and these better systemic agents. But even if you failed systemic and you then combine with hepatic arterial infusion, go back to the same systemic agent, we see good responses. So it is growing again.
So 50 miles from you would be somebody today having an operation in a small hospital. There's a few little spots of peritoneal cancer, and they're given some chemotherapy afterwards, and will probably progress and die. In real terms, what should happen to those patients?
I mean, in real terms, I think they should be referred to kind of a center that has an interest in, expertise in managing peritoneal metastases.
So that's the utopian position. I mean, we do not do almost any aspect of colorectal cancer care systematically correctly throughout the United States. I mean, we know that in the APRC and all that sort of stuff.
Yeah.
And this is fringe. I mean, we're talking about, abdominal peritoneal rates of 50% still in 2019. So if I'm a health service deliverer in a system, really? I mean, that's the challenge, isn't it? I mean, how to, because it still remains a niche piece of work, isn't it, to some extent?
Yes.
Would I, if I was a chief executive, want to build a cytoreductive HIPEC program? It's an attractor for quality seekers. So many people, many are called pure chosen. So it brings patients in from that standpoint. But does it make sense otherwise?
It depends on makes sense in what way. In other words, you could
CEO, so you know what way.
you could argue, and it's certainly if you're the insurance arm of the entity, as we are an IDFS, one of these integrated delivery and finance systems. You have to ask yourself, it costs a lot of money to put patients through these extensive procedures in situations where you're only improving survival by a couple of years. Now, there's been a lot of cost analysis that have been done for HIPEC that say, it's a reasonable approach and your cost per life saved or year of life is reasonable. But I think that's one question. The hospitals make money on the procedure because patients are coming in from outside and they're reimbursed, and so the hospitals like to have the programs.
Yes.
And it comes down to if the hospital has room and resources to support the program, but at the end of the day they're going to make money on it.
All right, well, obviously you have to stay here for a couple of more hours.
I do apologize.
Absolutely.
I use this computer every day, and this must happen once a year.
I think it's pretty clear you can blame UPMC then. It's not Dell's fault. So thank you very much, David. Nice standing talk. You're going to stay around.
Yeah.
So we'll have a 5-minute break, and we'll do it. Then I think you've got some cases that you're going to present.
Great.